Okay. Hello, everybody. Nice to see you here. Nice to have you here tonight. It's really a great pleasure to see how much of you are really interested in SGRT. I'm from the German Cancer Research Center, and I have worked a little bit more technical. Also, my talk is a little bit more technical than Jackie's. I hope you are not concerned about that. So, this is the outline of my talk. I will give you a short introduction. Then I will say something about commissioning and also report about DIBH. Myself has worked since almost 10 years with various SGRT systems. I have worked with a system from SGRT, with a Sentinel scanner. I have worked with a Vision RT system. Currently, we have 2 installations from Align RT in our center, one at the computer tomography and one at the Elekta Versa HD linear accelerator. The installation at the CT is more or less historical related because we were one of the first sites in Europe where the system was installed. And in the early days of the Align RT, it was provided that you can also acquire a reference image at the CT scanner. Therefore, we have 2. And in the while we have upgraded the system, we have used the chance to upgrade our CT scanner as well. So after all the technical evaluation and testing, we have 2015 decided to use the system also clinically. And we have then replaced our conventional camera system with a HD camera system. This is a little overview over our clinic in Heidelberg. It's far beyond the number of linear accelerators you can have, but we have 7 walls and we have a huge mass of system. We have 2 thermotherapy units. We have 2 linear accelerators from Elekta at the moment. There's still 1 Siemens Linac left, which will be replaced in the next year. Then we have a CyberKnife, and we are currently installing MR Linac, the ViewRay system. Last but not least, we have also our heavy ion facility. I'm sure you have all heard about it, which we can treat patients using carbon ions and protons at linear places or using our gantry. In this combination with this variety and at devices, I think our clinic is the only one in the world who is really in the possible to deliver all modern treatment modalities at the moment. So this image shows you our system at the Elekta Linear Accelerator before the upgrade. And after the upgrade, you can now see our new good-looking HD camera system. This is the image from our quite old Siemens CT scanner, which has the 2 new HD cameras mounted on the ceiling. And we then have, after the upgrade, to commission the system. When the service guys leave you with a new HD camera system, the system is perfectly aligned and it's working really fine. But well, we as physics guys want to be sure that the system is really doing what we want to do them, and so we have performed some workflow tests. In the first step, we have scanned this mannequin, which is labeled over there, have performed a standard workflow. So we have done a CT simulation, we have planned for this guy, and have finally exported the plan as it is intended in the use of Vision RT. I don't know if you are aware of the intended workflow in general, but nowadays the surface, which is the reference for the further treatment and for the positioning, is derived from the CT surface. So you're acquiring a CT and exporting the RT structure file and the plan file, and with this information you get the surface for your treatment. This is the purple image on this slide. The green image is the verification image, so to say the live image. And the arrow bars on the other side are displaying the actual translations or rotations. So with this test, we can show that at least the workflow going through the conventional treatment chain is doing what it's supposed to do. The next step was, as we have two systems, to check if the systems are working together. This is not necessary at every site, but we have scanned our quasar phantom. You're most likely familiar with it. We have set it up at the CT in the reference position, have then acquired a reference image using a line RT, not the CT, and have then exported this reference image by transferring the database to the system at the linear accelerator. We have then imported the system and verified the reference image acquired at the CT at the linear accelerator. And these are the results. They are within 0.1 and 0.2 centimeters, so I was not that highly accurate in setting the phantom up, but the system is really doing what the system should do. Last but not least, we wanted to know if, besides the static representation of the focus, also the coordinate system is working well. Therefore, we have again used our quasar phantom. We have set it up in the target point, in the reference point, have then acquired a reference image using a line RT, and then we have checked if the displacement of the system is working fine. If you know the system, you know there is a fixed shift between the reference point and the target point from 10, 12, or 14 millimeters respectively, and we have then performed the image registration using Elekta mosaic. So we have run the XVI imaging and have got the results that the shift can be performed out of the system, and the shift was then applied to the treatment couch. The verification image is the image at the bottom. You see the accuracy is quite high, and the coordinate system workflow was really verified. This is also a test where you can really check if all workflow issues are correct, because you are really working with independent system, completely independently, and if you got the same results from both systems, then it has to be correct. That's all. After the technical commissioning, we went now to the DIBH, our results for the first year. I'm quite sure you all know this famous paper from Sarah Darby, which is quite the rationale for doing DIBH at all. She states that the rate of the serious heart diseases in women is linearly correlated with the dose applied to the heart. So this is a little bit redundant. Sorry for that. I have here two CT scans, one in the breath hold situation, one in free breathing. And if you're looking at the doses delivered to the heart, this one means heart, I'm sorry for the German expression in the plan file. We find that we have in the free breathing plan in average at the myocard 1.8 gray, and if we are only looking at the anterior third of the muscle, we find at least also 3.1 gray. If we are looking at the same plan in the DIBH position, we have reduced the dose at the heart to 1.1 gray, and at the anterior part even at 1.6 gray. That's more or less the half. Again, a different patient, but the same motivation. These two CT slides from left to the right again, left is free breathing, right is DIBH, shows the same slice in the CT scan. It's the identical reference point. Yeah? And yeah, they are more or less comparable. If we are now going the identical distance caudal, then we find at the left side a completely different image than on the right side. While in the free breathing plan, no organ at risk is hit. You can see clearly that the liver and the kidney are also in the plan or in the target region in the DIBH plan. And if we comparing only the structure of the anatomy, so we have now looked only at the heart itself, at the form and at the position, then we find that we are some slides higher than compared to the identical slides in free breathing. This has certainly some impact on your plan. Now, looking at the plan, we find that we deliver in the PTV for both plans almost the identical dose. I mean, well, 0.86 versus 0.87 is not that big difference. But if we are looking at the difference at the myocard, we find again difference between 2.6 to 1.8 gray, only in the mean dose, and sparing the organs at risk, which is also very important at this point. We find also some benefits, not that huge, but we can spare half gray roundabout. I think you have asked after the compliance of the patient previously. This was also our concern. We have we have the questions that the patient has to be able to stop breathing for at least 20 seconds, and we train this before the CT. So in an ideal world, we could imagine this a little bit different. We wanted to ask the patient to come prior to the CT scan to practice and to train with the surface system, but in reality and in clinical routine in the workflow, it never happened. So we really train the patient directly prior the CT scan. We are lucky to have an Aligner TE system at the CT scanner, but you can train this at your linear accelerator as well. It's mandatory that you have some kind of a trigger system. I think it's not really important which trigger system this is, but you have to check and to train if your patient is able to stop reproducible at the same position. Given this, we performing 2 scans. We performing a CT scan in free breathing, and we also performing a CT scan in DIBH after the training. And with that, we are doing 2 treatment plans. We do this double planning due to the fact that we wanted to have a fallback solution. We also have concerned about if the patients are able to do this, if it's working fine. So if anything goes wrong, we wanted to have a plan B. In the first time, this were great. This was no problem, but nowadays it leads to problems. I will come to this a little bit later. For the planning itself, we are doing 2 identical reference points and also identical target points. But if we are planning to the free breathing plan, we are doing 1 VMAT plan from a dual arc for 140 degree roundabout. And if we are planning for the DIBH, we are planning 2 dual arcs from 40 to 60 degree to get in the area from 20 to 25 seconds delivery time for 1 arc. This is a short overview of the workflow you are doing. You are creating, you are setting up the patient in the system, and you are importing the structure set from the DIBH plan. Then you're creating a ROI. I think Jackie has also mentioned this. And with this, we are then setting up the patient. we are really using our DIBH reference with our RI to set up the patients using the monitoring mode. I think quite comparable you have mentioned previously. Then we use the system to coach the patient in the DIBH position. And if the DIBH position is reached, then we are acquiring one portal image and a reference image using a line T at the same time. That's not a big issue. You have to hit 2 different buttons at the same time. That's all. If then, after the radiological acceptance from our physician, the position is is acceptable, is all right, then this just acquired reference image is the reference image from now on. With this one, we are doing the coaching and the motion monitoring and the treatment. So to sum up our first experiences, we have seen from the technical side of view a really good accuracy in the whole treatment chain. And for the calibration accuracy, we found values better than 1 millimeter. A quite important point is, in my eyes, the training and the stuff. If you got the stuff at your side, then the system is working in routine. The radiographers are really very easy to train and are very quick in understanding the issue of the system. And in this context, also the training from Vision RT is valuable. I'm only to mention this, if you're buying a system, you got 3 trainings. The first training session is in the training center in London. The second training, then these trained guys are teaching your stuff at home, and this is verified using a webinar. But the third training phase is, in my eyes, the most important one, because there is an application specialist from Vision R2 on site at your clinic at that date where you want to start with DIBH treatment. Believe me, I have worked several times with the system and reflected all questions prior to the first setup, but if it comes to the clinical routine, then suddenly question arises you have never thought about it prior. So this guy who is able on site to answer questions is really highly valuable. In our first year, we have at least 50 or 60 patients treated using DIBH. And these days, we are treating 15 patients a day. And this leads to workflow issues in between, because I mentioned this in the first time, we are planning the patients twice, which is a huge effort for this amount of data. And we have, as I have stated in the slides over our department, we have 2 Elekta linear accelerators, but we had at the moment 1 Vision RT system. So we have combined these 2 linear accelerators that way that they can back up each other. So one machine can be available for the QA, for the dosimetric tests, and for the service one day, and then you can shift the patient ideally to the other machine, so you have no issues in your workflow from the patients. But this is not working with DIBH patients, as we have only 1 system installed at the time. Currently, we are scheduling all DIBH patients in the morning, as this is the time where both machines are running. But, well, with 15 patients using DIBH, it's quite tight schedule. One solution could be buy a second system. We're really reflecting this, but yeah, well, you know this from your clinical routine as well. You have to find somebody who gives you the money for this. And quite great impression from my eyes is the patients are really interested in doing it right. They have with this system a the impression that they really can assist you in the treatment of their cancer. This is from a high psychological value for them. So we have also women who asking after SGRT, as younger women are possible to ask Google what's the best treatment for their disease. So there are really some ladies who are asking directly after DIBH treatment, not especially for SGRT for sure, but for the DIBH treatment. This is a common theme in the community, I think. We had no fallback to the free breathing plan until now out of the patient issue. We had fallbacks due to technical reasons, which I mentioned a few moments ago, where one system is down or something like that, or one linear accelerator is in service. Then we have to use the other plan because we have treated the patients at the other linear accelerator, but not from the patient side. They are all doing very well. And another really crucial point is the treatment time. When we have started using DIBH, we have blocked a double slot per patient because we have not know how much time will it need to get familiar with the system from both sides, from the patient and from the staff. But we have learned after, I think it was a week or a week and a half, that we really can go back to the normal treatment slot, and we are treating our DIBH patients in the same time we patients without DIBH. With this, I'm already at the end. I want to thank my team, who is really mandatory to do such an impressive implementation in the clinical routine, because this is always the issue from the physics side of you, that you have to convince the staff and the physicians. And here, I thank you for your attention.
Thank you very much. I think you'll all agree, another very informative presentation. And I think what stands out to me is at both centres, how they've rigorously tested the system for accuracy. And it's living up to the claims that we make. So that's, from my point of view, really good to hear that from two independent people. So I'll open up for questions.
I wondered if you could tell me why you take the reference image with the Vision RT rather than just going straight from the CT-based reference image.
This was the first idea of the system. This was an idea from Vision RT, I think, 15 years ago. So this is no longer actual. Or did I get your question wrong?
I thought you mentioned that you take the MV images on treatment.
Yes.
You take the radiographic images, and then at the same time you take a reference image.
Okay, now I got it.
Yeah.
Yes. Why are we doing this that way? We have different setup locations. Yeah. We are doing the planning at the CT dataset, and if we are then setting up the patient for the first treatment, then we are doing a radiological verification of the setup. Exactly once. If the radiological setup in DIBH position is working fine, and then we can use this setup as a reference for further treatment. We can then spare additional radiological imaging. And therefore, as we don't know prior if it's fine, therefore we are acquiring both images at the same time. So we are acquiring a reference image using a line RT, while we are acquiring the verification radiological image. And if the radiological image is fine, then we can use the acquired reference image from a line RT for further treatment. Then we can spare additional radiological images.
I came late, so my apologies if you discussed this already. Are there other disease sites where you would like to extend this approach? Of course, the example you showed is probably one of the best one can think of in terms of correlation between the surface and what you want to hit. Are there other disease sites where you think that this approach is applicable very well or very well?
We are at the moment thinking about expanding our disease sites to lung and liver treatment, but this is an issue of the huge heterogeneity of our clinic. It's really complicated to organize the workflow and the patient streams so that you can start a treatment in a considerable amount of time. We are thinking about it, but we have not managed yet to prepare all that we can start it.
I would like to ask if I saw that you have tomotherapy units in your department also. Do you think that system like this could be implemented on a tomotherapy unit, or do you know
at the
what
tomotherapy unit, it's complicated to implement because
Yeah,
you
because the patient enters
can't
the
look with a standard geometry inside the bore.
Okay, so there are no such installations, also the people from the company, can you tell us?
I'll just refer to one of my colleagues down here.
We do have some customers that are using tomotherapy with the Line RT for patient setup, so ensuring that the patient's in the correct position before they're taken into the bore and imaged at that point, and to reduce the amount of times that you're bringing the patient in and out and adjusting their position. In future, we're looking towards whether we can expand that as well to do monitoring during treatment as well.
Okay, well, thank you very much, and thanks for your engagement. I think you'll, all agree some really useful information to share with you this evening.